Good morning, everyone. Good afternoon. Good evening. Welcome you all to this webinar. Today's webinar on innovative strategies in family planning is the first of the series on accelerating evidence use in policies and programs. The webinar series was launched in December last year, led by the ECSA Health Community Secretariat and the University of California, San Francisco, with support from Ifakara Health Institute, Infectious Diseases Institute, Africa Academy for Public Health, and University Research Company. Once again, we bring together perspectives from policymakers, researchers, advocates, ministries of health, program implementers from the ECSA region. And today, we will particularly share valuable lessons from East Africa. We would like to create an opportunity for the family planning community to connect, to discuss, and share evidence and promising practices, to reflect on local champions and innovative strategies in family planning. The collaboration and collective support will go a long way in ensuring RAMCA systems in the region are resilient even amidst the pandemic situations to ensure person-centered, high-quality care. We need to continue sharing learning and advocating for evidence-based interventions led and implemented by our own member states. We are pleased to host policymakers, researchers, implementers from national, regional, and international experts in maternal and newborn health to deliberate on innovative strategies in family planning. Ladies and gentlemen, access to modern contraception, especially for girls and young women, issues of quality and equity. Young people are speaking for themselves about transparency and accountability. These issues that confront us can no longer be ignored. The Sustainable Development Goals and Global Strategy for Women's, Children, and Adolescents' Health call for universal access for family planning as a human right for women and girls. Reducing unmet need remains a challenge not only for Africa, but for the global health community as a whole. Family planning statistics in the ECSA region ranged from 30% in Uganda and Tanzania to 76% in Mauritius. Universal access to effective contraception ensures that all adults and adolescents can avoid unintended pregnancies. In particular, the COVID-19 crisis is exacerbating inequities with reported disruptions in essential health interventions, disproportionately impacting the most vulnerable women and children. And COVID-19 recovery efforts require multilateral action and continued investment in development. These challenges require consolidated, sound, and available evidence that can inform policies and strategies that are sustainable and respond to the needs of the stakeholders. The importance of implementation science and research partnerships can collaborate across a range of stakeholders to generate evidence to improve policy and program implementation is more important than ever. Today, we will hear from innovative strategies in family planning and learn valuable lessons from East Africa. Our speakers are Dr. Euphemia Sibanda. She is the epidemiologist from the Center for Sexual Health and HIV Research in Zimbabwe and senior lecturer in global health and epidemiology at Liverpool School of Public Health. She will present a review of unmet family planning needs and interventions for improving uptake and contraception in East, Central, and Southern Africa. The second speaker will be Ms. Ramatu Daroda. Ms. Daroda is UNFPA Family Planning Policy Advisor, East and Southern Africa Regional Office. She provides technical and policy guidance on sustainable family planning programming through regional economic committees and UNFPA country offices in the region. She will present pooled procurement solutions for a defined set of priority essential health commodities in East African communities. The third speaker will be Dr. Judith Aloyo. She is the Technical Director at the USAID-funded Regional Health Integration to Enhance Services, North Acholi Sub-Region. Dr. Aloyo is a Technical Director at the USAID-funded Regional Health Integration to Enhance Services, North Acholi Sub-Region. Activity managed by a university research company for the past 4 years. Judith has been a team lead of over 44 technical officers, providing strategic guidance to district-based programming of the Comprehensive Health Program in the 8 districts of the Acholi sub-region. Dr. Judith Aloyo will speak to us today about long-acting intrauterine devices. The next speaker will be Dr. Kiadondo. She is a population and health advocate with over 20 years supporting national and field-based projects in reproductive health, gender, HIV, population and development. A medical doctor trained in demography and currently the director at Family Health at the National Population Council in Uganda. Dr. Kiadondo is a Colin Fellow of Oxford Institute of Population, Aging, and is leading the efforts that will get Uganda on the trajectory to harnessing the demographic dividend. She's a researcher with Child Health and Development Center at Makerere University and a part-time lecturer at Makerere University of Public Health. She will provide policy reactions to the case studies presented today. So I will invite our first speaker, Dr. Euphemia Sibanda, to give her presentation.
Good morning, good afternoon, or good evening, depending on where you're joining us from today. I would like to thank the organizers for inviting me to give this talk, where I will review unmet need for family planning and interventions for improving uptake of contraception in Eastern, Central, and Southern African region. Let's start by defining unmet need and its magnitude. A woman has unmet contraceptive need if she's not on any contraceptive method, is fertile or able to have children and is sexually active, and reports either not wanting to have another child or wanting to delay the next child. This slide here is showing 2020 estimates of unmet need in different countries for all women aged between 15 and 49. And as you can see, there are high levels of unmet need across all countries, although there is heterogeneity. If we're looking at the Eastern and Southern African countries, we can see that percent unmet need ranges from 8% in Zimbabwe and Botswana to as high as 21% in DRC and 27% in Angola. This compares with levels of much less than 8% in the European region, for example. These data here are for all women. If we look at data restricted to married women or those in union, we find that unmet need is much higher. For example, in Angola, it goes up to 36% and 26% in DRC and 10% in Zimbabwe. Among women who are using contraception, we find that uptake of long-acting reversible contraception is quite low, which means that in many women, they rely on user-dependent methods which are fraught with adherence problems. Uptake of IUDs is particularly low, with many countries reporting uptake of 2.5% or lower. Groups with highest unmet need include adolescents, migrants, and other groups that are shown on this slide. They face additional challenges unique to them in addition to the usual challenges that women face, and I'll discuss some of them in the next few slides. Unique challenges for young people include laws, cultural and religious practices that limit or restrict access to young people or to those who are not married. And there's evidence that young unmarried women have more unmet need compared to older women. And this is likely because of lack of knowledge, because in many settings, comprehensive sexuality education is not given, and where it's given, it is not targeted at everyone. Young people also face challenges that healthcare workers are unwilling to provide sexual and reproductive health services to them, and they also face challenges related to access. They don't know where to go to access services, and they also don't have money for user fees and transport. Because of these challenges that young people face, we see these staggering statistics where 23 million young people aged 15 to 19 years globally have unmet need for contraception, and half of young people aged 15 to 19 have unintended pregnancies, and just under 4 million girls aged 15 to 19 undergo unsafe abortion every year. Among postpartum women, unique challenges include perception that pregnancy risk is low when the woman is not having her regular periods, and also there is fear of hormonal contraceptives that they may reduce milk flow or that chemicals may transfer to the baby. There is the unique opportunity to promote uptake of services in antenatal and postnatal services, because research has found that women who attend these services are more likely to take up contraception. Now let's go to female sex workers. A systematic review that was conducted to determine the incidence of unintended pregnancy among female sex workers found that incidence ranged from 7.2 to 60 per 100 person years, and with a median incidence of 26.9. Challenges unique to female sex workers include stigma and discrimination and criminalization, which prevent access of services. And for young female sex workers, they additionally face those challenges that are unique to young people that we have discussed. Now let's discuss interventions for improving contraceptive uptake. The first is task sharing, where there is expansion in the levels of cadre who can appropriately deliver services. An extract from the WHO guidelines is shown on the figure, and for example, you can see that promotion of maternal and reproductive health information and education can be done by all cadres of all levels, including community health workers. It also shows that under monitoring and evaluation, lay health workers can initiate and maintain women on injectable contraceptives. Task sharing has been evaluated widely and found to improve uptake of services. An example from Ethiopia here shows that task sharing for IUCD and implants resulted in an increase in uptake of these long-acting reversible contraceptives, which in turn decreased unmet need during the period between 2011 and 2019. Integration is another WHO recommended strategy that has been known to increase uptake of services. We already know, for example, that uptake of immunization among babies is quite high. Hence, immunization clinics provide a unique opportunity to reach the baby's mothers with contraceptive services. Other services where women attend regularly have been found to be good for integration of family planning services, and these include HIV clinics and other clinics, for example, those providing comprehensive integrated sexual and reproductive health services. Digital technologies are becoming increasingly popular for providing information and supporting engagement with services. Most of them use SMS-based systems, and I am showing an example on this slide called the M4RH system, which is an on-demand SMS program providing reproductive health information and facilitating users to find their nearest family planning clinics. It has been evaluated in Kenya and Tanzania and has been rolled out in other countries. Now let's talk about self-care, which is defined as shown on the slide and has self-management, self-testing, and self-awareness components. The 2019 WHO self-care guidelines for sexual and reproductive health recommend implementation of self-administered injectable contraception, and they also recommend the offer of oral contraceptives over the counter. Now we know from the HIV field, for example, that self-care can have game-changing results. For example, with HIV self-testing, there was a large increase in the number of people who took up HIV testing, including individuals who would not otherwise test. So we anticipate that implementation of self-care for sexual and reproductive health will result in a step increase in the number of people who use contraception. And digital tools are likely to have an important role in implementation of self-care. Just a note to say that self-care is another form of task sharing where tasks have been expanded to individuals and community health workers. I'll end by touching on an intervention that is in the pipeline, the dual prevention pill, which combines PrEP with a combined oral contraceptive pill in a single tablet or pill, and it promises to be a game changer for both HIV prevention and contraception. Research is currently ongoing with plans that the product will be introduced in prioritized countries in 2023. So in summary, unmet need is unacceptably high in East and Central and Southern Africa, and there is need to implement those interventions that have been recommended to improve uptake of services, and these will include self-care and digital interventions which are promising to be game changers for family planning. Thank you.
Greetings to you all and a warm welcome to this family planning webinar entitled Accelerating Evidence to Use in Policy and Programs. My name is Dr. Aloyo Judith and I'm the Technical Director at RHITES North Acholi. I'm privileged to share with you the progress that RHITES North Acholi has made while implementing the recommended high impact practices in order to improve our programming and also family planning service delivery. I'll be sharing with you a couple of slides that highlight the progress and the steps we have taken in this journey. And we see a 5-fold increase in IUD usage among women of reproductive age within the Acholi sub-region. We are located in the northern part of Uganda, covering 8 districts with a catchment population of about 1.8 million people. Key to note is that 400,000 of these are refugees. We also reach out to 315 health facilities, with the highest being the regional referral, but also we do support the health center tools and the private for-profit clinics that offer some form of family planning. Key to note is that only 40% of our populations are able to access a family planning service, and this is because of the poor road network, but also the fact that these facilities are widespread apart. Statistically, we see that we have a high unmet need of family planning services, which stands at 28% in comparison to the national at 38 or 39%. The contraceptive prevalence rate is about 30% and a very high total fertility rate at 5.5. At the onset of the project, we were able to do a baseline analysis as to where we stand and family planning. We can see in this snapshot that there is an even family planning method mix, but also most importantly, we do have low uptake of the long-acting reversible permanent family planning methods. So as a project, we set out to contribute to the government of Uganda mission of expanding the reach and the provision of a method mix, including the long-acting reversible contraceptives. And this in particular were the IUDs. And we did this by embracing the high impact interventions, which are a set of evidence-based practices that have been vetted by international experts. And these are in the formats of service delivery, social behavior change, and enabling environment. In order for us to be able to achieve or contribute to this mandate by RHITES North Acholi, the project went out to conduct a gap analysis. And this gap analysis was done using 4 methods. One is that we were able to do the capacity assessment of our health workers through interviews. We also did a client satisfactory survey. We also able to do a dashboard tool. And lastly, we handled the facility inventory assessment to look at the type of tools or equipments that are available. This brought for us 3 main themes in terms of the barriers. We have the provider-related, patient-related, and the health systems. And on the next column, you're able to see the type of barriers that we were able to pick out from these different methodologies. Key to note is that we had skills gaps as coming out as topmost, in addition to the limited access to the correct family planning, but also we had significant poor data management and documentation, as well as lack of equipment, which stood at 34%. So to help us prioritize our interventions, we had to apply the 80-20 Pareto rule, which looks at the items that were scoring most and contributed to the majority of our problems, handled these, and were able to give us high or great improvements. We were able to also complement this with a QI methodology, where we had 10 collaborative sites working on a number of interventions. These were intensively engaged for 1 month, day every year, and then scaled up the tested changes. Coupled with that, we also embraced the high impact interventions, particularly looking at 2 arms. We had the service delivery, which focused on access, acceptability, and quality, as well as the social behavior change, high impact interventions that looked at influencing the knowledge, beliefs, and behaviors, as well as the social norms. Not forgetting the health systems, we are also able to improve on our health management information systems by providing the healthcare workers with updated tools for documentation, but also support the stock management through online ordering, and also equip the different health facilities with the needed IDU assets. Having done an intervention or implemented for close to 3 years now, we're already beginning to see some promising results in the region. And this is because of embracing the high-impact interventions. We conducted a number of job mentorships, training, and also equipping the health workers at both the facility, but also we were able to do this at the community. One key component in terms of the service delivery is the issue of the task shifting element. You can see from the numbers in the brackets, we have fewer medical officers and clinic officers compared to the midwives or the nurses who are able to be available, and therefore improving in terms of the access of these family planning methods. Key to note is that we mentioned 40% of our communities are able to provide or receive a service. What remains of the 60%? We have the community health workers, particularly the community doctors, these are the VHTs, but also we have the peers who help us, particularly in our DREAMS program, which is determined, resilient, empowered young girls to ensure that they're able to access some sort of family planning education, as well as the services that are available. On our left, we are able to see a trend line that shows a positive trajectory of our engagement at the collaborative sites. And this is particularly one high impact intervention where we see a 3 times fold increase in the number of women take up family planning during the postpartum period. And these are some of the changes that we are able to encompass and ensure that we see this positive trajectory. Looking at the social and behavior change high impact interventions, we are also able to record and share with you some early results. This particularly looks at the community-based family planning, but also improving access through the community outreaches. And most importantly, we have the interpersonal communication agents who are expert clients that help to dispel myths and misconceptions, but also provide this form of continuous education on the benefits of IUDs and any other family planning methods that the beneficiaries would usually need. Here is a snapshot of one of the peer providing some counseling, but also health education in terms of the services that are available. And therefore these mothers and the young girls can be able to pick what they feel have been necessary. Now we have a summary here in an Excel sheet of early results as a result of the community-based family planning that we held within the different parts of the region. Key in this slide is that we have about, of the people that come for the family planning or the community outreaches, 78% of them are able to walk away with some sort of family planning service. However, we still have a very suboptimal level of referral from the community for the long-acting family planning contraceptives. Overall, having implemented for close to 3 years, we are proud to show an improvement in terms of the comparative method mix. Here is a dashboard that shows us the different family planning methods highlighted in the different colors of pink, blue, green, yellow, and a bit of red or maroon. And on the x-axis, we are able to see the number of implementing partners and measuring their different family planning services or availability in terms of the different quotas. The takeaway message from this slide is that after having implemented for this period of time, RHITES North Acholi has been able to have an availability of all or an improvement in the method mix as comparison to the first slide where we had only injectables. Here we see everything is available. And key to note is this dotted part where we have a 3 to 5-fold increase of IUD uptake in comparison to the other implemented mechanisms. We have it at 5, 3, and at 1%. Now, opportunity for improvement arises in this slide, where we need to see how best we can be able to improve uptake of the permanent family planning methods, which is at close to 2%. Overall, having seen what we have been able to walk through the different embracements, there are a few take-home messages that I want to leave with this meeting or discussion. Our key score point for this programming has been integration of the service and social behavior change, health impact practices in our programming. And this, we can attestfully say that it has significantly improved our method mix, but also we are able to register a 3-5-fold increase in terms of the usage of IUDs among women of reproductive age. Despite having these excellent results, we still have some blood or hiccups in the guidelines on how to implement the high impact interventions. We have issues around task shifting that remain very unclear, especially expanding the service base to those that are within the facilities. And then also the issue around community-based family planning, where we have stock management and reporting, but also how can we be able to leverage on the existing platforms. For example, the people living with HIV and AIDS have the community development distribution points, but also we have the DREAMS platform that we can be able to make sure that we pick on. So that we have had as RHITES North, actually, I would say that embracing the high impact interventions has enabled us to achieve a lot more of this. As I conclude, I would like to wish you all a great knowledge sharing in this family planning webinar. Thank you very much for actively listening, and good deliverance.
Good morning, good afternoon, good evening, everyone. My name is Ramatu Daroda. I'm the Family Planning Policy Advisor for UNFPA East and Southern Africa region based in Johannesburg. My presentation is on the report and recommendations of a feasibility study conducted on cross-border supply chain solution for reproductive health supplies in the EAC community. We all know that strong supply chains are critical to provision of family planning services, and to avert stockouts, innovative supply chains are required. The EAC, with its contiguous borders, manageable size, provides a living laboratory for innovative supply chain solutions. The partnership for this study included the EAC Secretariat, University of Rwanda Regional Center for Excellence for Vaccines, Immunization, and Health Supply Chain Management, Ms. Quintal, who are the consultants for this study, and UNFPA ESARO. This was funded by DFID Premdesa program. The countries, of course, are Burundi, Kenya, Uganda, South Sudan, and Tanzania. And quickly, we want to look at what is supply chain. Currently, countries use their funds to procure commodities at national level, and commodities are received at national warehouses from manufacturers and sent out to various parts of the country. And we stock out, either transfers are done from the warehouse or new procurements are made. In pooled procurement, regional pooled procurement, both national and donor funds are pulled together. Standard quantification and procurement will be held at EAC level, and quantities supplied directly to the countries or through a central level EAC warehouse. This is cost effective, efficient, with less bureaucracy. In cross-border supply chain, in addition to pooled procurement, reproductive health commodities can be transferred from one national warehouse to another in case of emergencies or shortages. So countries can view inventories in each country on an online dashboard and then make requests, and this request can either be done regionally or from another country warehouse. What are the plans? The long-term, medium to long-term is either things remain as they are, the way countries do things, or for improved efficiency, which is also optional for countries to participate, pooled procurement or group contracting can be done. And this can be started with a smaller set of commodities, standard procurement processes, and countries can see what stock is available in all other countries. Cross-border supply chain solution can also be positioned as an emergency response. We have seen with COVID the need to be able to have stock available so that services can continue. An independent body, UNFPA, USAID, or other stakeholders could conduct regular monitoring to ensure that benefit for all countries are aligned. The objectives of this study were to assess the existing supply chains and data flow at regional and facility level to access the systems, determine the requirements for making this cross-border supply chain a possibility, a reality, explore the possibility of having centralized cross-border distribution that can be used to replenish commodities, determine the needs, determine what needs to be done by respective stakeholders to achieve this aim, and then to develop a concept for an ICT-based dashboard that will show the balance of stock in each country. The approach and methodology, I won't go into details, but formative meetings and preparatory work for data collection was done, survey planning, team mobilization, and data collection itself was done. The feasibility study itself was conducted, and then recommendation and action plan developed. The methodology included pilot testing of the tools with government officials, donors, in Kenya, and then interviews were conducted across the EAC countries, and information was collected from donors, custom officials, health facilities, government officials, and warehouses using a structured questionnaire. The limitation of the study was that not everybody that was to be interviewed was available. Not all parts of the questionnaire was filled out, although some of the information was collected during a planned meeting. The learning and recommendation is that cross-border supply chain is feasible if the following recommendations are adhered to. There is political will and commitment from every country, capacity building for both EAC and at national levels. Procurement legislation and harmonization needs to be done. Financial systems, strong financial systems need to be in place. Information sharing across countries, and favorable pricing of commodities. The supply chain solution dashboard, the key highlights are that this dashboard will depict stock balance status for each reproductive health commodity at country level. And there will be 3 levels of rights to view this: the EAC Secretariat level, the Ministry of Health level, and then reproductive health program heads also will be able to see the stock status of their own country and also the balance in the region as well. This is what the dashboard looks like. We can't go into details, but definitely for every commodity, you will see what is stocked out, understocked, what has adequate stock, and what could be overstocked. The strategies for success require the EAC to follow up on awareness raising and specifically buy-in from key decision and policy makers, implementing and regulatory bodies and other development partners. Currently, buy-in is being awaited from Kenya and Tanzania. Again, establishment of a regional medicines procurement committee to adapt existing regional supply chain guidelines and standards for prioritized supplies, agree on the products that can be pulled for procurement, adopt a roadmap and procedure for adding or removing products, and then strengthen the EAC Secretariat and regional coordination for this pooled procurement. And of course, capacity building plan for the national medicines procurement agencies. You have to look at HR requirements, processes, automation, and also the fact that periodic updates need to be provided on these systems. And that's the end of my presentation. Thank you.